He's the guy. So I'm glad we've got him for an hour, and I'll welcome Dr. Michael Noble to talk about proficiency testing. Thanks, Mike.
Thank you, Tyler, and welcome all. This presentation is focused not only on the proficiency testing that we do at UBC Clinical Microbiology, but is on a larger scale as well. So the learning points that I want to go through, and I think you have these, is that proficiency testing is the most common national and international measure used to detect laboratory error with a goal of medical laboratory quality improvement. And participation in proficiency testing is a requirement for all national and international accreditation in countries in all continents, I think also including Antarctica. Proficiency testing is not the only measure to detect laboratory error, but is the most accurate because it's of its objective and prospective methodology. And finally, proficiency testing traditionally addresses errors only in the examination phase of laboratory patho workflow, but it can also contribute to the pre-examination, post-examination, and a new phase that I'll talk about today, the para-examination knowledge and performance. So a little about me. I grew up in Ontario. I went to what is now called Western University. What a joke. And I did training in internal medicine, infectious disease, and medical microbiology, and then moved to Halifax and came here in 1983. And in addition to being involved in microbiology and infection control, I got very involved in proficiency testing and quality management programs. I had the opportunity to chair the Canadian Mirror Committee for ISO Technical Committee 212, was very involved in the creation of 15189. And I currently work as a consultant for another proficiency testing program called One World Accuracy. This is a common picture of the medical laboratory, medical diagnostic process, of which the laboratory is one step in the process. Some say the Centers for Disease Control in Atlanta, the Division of Laboratory Systems, says that 70% of today's medical decisions are predicated on laboratory results. I don't know if that's a right number. I think it's probably a wrong number. But what it does point is that there's a lot of decision-making that happens around the production of medical laboratory information. And way back when, back in 1974, Ray Bartlett, actually it's 84, wrote a book called Quality, Cost, and Clinical Relevance, and described something called the laboratory testing cycle. This cartoon, clearly dated and sexist and a lot of negatives, nonetheless points out the point that what starts at the patient, somebody, a physician, makes some sort of a provisional diagnosis, thinks about tests to create, writes them down on a piece of paper. That order gets passed through some people or a computer. Somebody else comes along and collects the sample. And they may take that sample to the laboratory, the four walls of the laboratory, or may go another route. Somebody in the laboratory actually has to do the test, interpret the results, create a report, have the report signed. That report has to go through somebody or a machine back to the person who ordered the test, who tries to put that into perspective, and then does something to the patient as a consequence. So it all begins and ends with the patient. And in fact, is not a simple, I went to the lab, they did a test, I got a result. It's actually very complex. And the problem with complexity is that every step along the way is another opportunity to do something wrong. And so there are many ways in which laboratory testing will end up with error. So here's a simple a bipolar approach. You do a test, and you do the test performed as expected, and what you get is the ISO definition of a correct result. It's timely, accurate, clinically relevant, confidential results with an interpretable report. That's what happens when things go well. When things go not well, you end up with either something that we call a near miss, which I think is a misnomer. It just means that we didn't look very closely, or you end up with healthcare inconvenience, or you can end up with harm to the patient, harm to their family, harm to the facility, harm to the community. So doing tests wrong can have many consequences. And in our course, we talk about the costs of poor quality, the result from laboratory error. So there's a question about, well, if errors occur, and we know that they occur, how often do they occur? And the answer is, I don't know. We look at this from a bunch of different directions. One is through the patient safety learning system. We do it through international activity. And the reported error falls somewhere between 1 in 10,000 tests to as low as 3 out of 100, 3%. That's a big range. But that range is complicated by the fact that in this country, in Canada with barely 37 million people, we do over 1 billion tests per year. Just in COVID, we've done over 60 million in the last year, 60 million tests in the last year. So that there's lots of opportunity for information, and there's lots of opportunity for wrong information. And so, and I'll show you some of the data that we have that justifies, I think, the 3% comment. Anyways, through the testing process and trying to collect information, people have looked at this over the last 20 years, and they find that 80% of reported errors come before the sample ever got to the laboratory. About 15% happened after the test left the laboratory, and about 5% happened while in the laboratory. I can tell you that that's largely bogus, because what it really points out is that laboratorians don't like to report their own errors, but they love reporting the errors that happen before the sample gets to them. Physicians like to report errors going back. And so what we have is a process that's very difficult to collect information. But we do talk about the pre-examination, post-examination, and examination phases. In international, that's the international terminology. In the United States, they tend to use pre-analytic, post-analytic, and analytic. Both are right. I tend to use the examination terminology. Well, if you're going to find that if those errors exist, they only exist once you find them and do something about them. And the primary way of doing something about error and finding it is by doing audits, by having complaints and an investigation as a result of a complaint or an injury. Sometimes it leads to official inquiry. Often it leads to report generation. But the single process that has the highest likelihood of a rapid detection and prospective change is proficiency testing. Once again, I tend to use the term proficiency testing or the term external quality assessment, EQA. In France, it's EEQ, but you will find in literature, except in the American literature, the term EQA is the term that's becoming much more popular. Okay. So here's how proficiency testing works. And you went through this, all of you went through this at one time or another in a chemistry laboratory or in any other laboratory where somebody, a teaching assistant, came and gave you a sample, which they called an unknown. And they expected you as a student to analyze that sample and come out with an answer. Well, every medical laboratory in the world that is accredited has to go through that same process all the time. If you go through that process and the sample looks like a typical sample, and it should look like a sample, but looks like a typical sample, and it should be reported back to the agency, and the agency analyzes it and looks at the results and sends those back to the laboratory. So if the laboratory did the sample correctly and they got back a good result, then we tell, in this province, Diagnostic Accreditation, or in Alberta Health, that the laboratory is proficient or they're competent or they are meeting requirements. If they did the sample and didn't get a correct result, we tend not to use the opposites of those terms, but we do tend to use the phrase that there are opportunities for improvement or that the laboratory is not meeting the needs. And if those not meeting the needs happen often enough, then at some point, the accreditation department, the accreditation program may choose to put in some requirements and may even close the laboratory down. So proficiency testing is not new, it's not current. In fact, it goes back to the first written report, goes back about 100 years ago in the Hungary National Institute of Hygiene. For medical laboratories, the literature is much more current and dates back to 1947. There's a story that I think is true, and you can read this article in the American Journal of Clinical Pathology, and it's still in the library and is a useful article to look at. What happened was that Belk and Sunderman, who were both in the Army, came back to the laboratory, and they in Philadelphia, and they discovered, much to their horror, that a common practice had developed among clinicians, and that is that they would collect samples from patients and they would send them to multiple laboratories. And then when they'd get the results back, they would look at the set of them. They may mean the results, they try other averaging, they'd look around, they'd try to make a decision, and then they'd go forward. And this appalled Sunderman and Belk because they said, this is an insult to us. You don't trust us. We're right, and how dare you go through this exercise? And so they created this study to demonstrate how laboratories were still good. What they did was they took some hemoglobin or glucose or protein, albumin, and they created simulated samples. And they sent those samples through to about 60 laboratories over 2 runs. And they discovered, much to their horror, that there wasn't a single laboratory in the 60 that got all the samples right. About 10% of them got most of them right, about half of them got half or less, and there were a substantial number that didn't get any right. And so they repeated it and they got the exact same result, and they said, This is a problem. The docs are right, we're wrong. This is not the way to run laboratories, and we have to fix it. And so, being in Philadelphia, they went to the College of American Pathologists, had meetings and discussions. And 10 years later, the College of American Pathologists created a proficiency testing program called the CAP Proficiency Testing Program. That was in 1958, and it continues on today. CAP Proficiency started for microbiology a little bit later, and it was actually run by Ray Bartlett, the person who wrote the book, and that became known in 1968. In 1967, the federal government introduced the Clinical Laboratory Improvement Act as a form of legislating the requirement for proficiency testing as a quality measure for laboratories that receive federal funding. But they decided that rather than go through the process, they would use it as a threat. If you guys don't shape up, we're going to implement CLIA regulations. Well, by 1988, laboratories had not cleaned up their act, and so hands were tied, and Health and Human implemented CLIA, and CLIA regulations have occurred since 1988 throughout the United States. And continues to do so, and likely will not change. Canada was a little bit slower, but not that much. 1974, the province of Ontario created the Laboratory Proficiency Testing Program, LPTP, for chemistry, hematology, and microbiology. In 75, the province of Quebec developed their proficiency testing program in the Laboratoire Public Santé de Quebec, LSPQ. In 1983, when I first came here, I was asked if I could set something up for microbiology because the laboratories in Lower Mainland could not get samples across the border from the United States because they contained live microorganisms. So we set up CMPT in 1983. And by 1990, it was across Canada and international as well. And around the same time as that, 3 or 4 other programs developed through UBC in chemistry, in molecular, in pathology. And so we in Canada have nothing to be embarrassed about. We have about 50 years of experience of internationally recognized and achieved proficiency testing program. I will tell you that I take it as a personal insult when other laboratories choose to use a College of American Pathologists, but that's just me. And of course, every laboratory is entitled to use the programs that they want to use. So that was kind of Canada and the United States. In 1994, the International Organization for Standardization, ISO, decided that they needed to have a quality standard for medical laboratories. And it was predicated off an American system, initially called NCCLS, now called CLSI. And it took 10 years to create that standard. But in 2000, and I've got an error here, it's 2003, not 2002, ISO 15189 was written and published and circulated. And that standard says, and those that know about standards, the word shall means must, you have to do it, you don't have a choice. The laboratory shall participate in an interlaboratory comparison program or EQA program or proficiency testing program appropriate to the examination interpretations of the examination results. So if you want to be accredited internationally to 15189, you have to participate. And the laboratory shall monitor the results of the proficiency testing program and participate in implementation of corrective actions. In other words, it's not okay to say, yeah, I participated, we did wrong, and so better luck next time. No, if you have an error, you are required to demonstrate that you've sought to understand why you've done a corrective action. The standard goes even further. It says that interlaboratory comparison programs, PT programs, chosen by the laboratory shall, as far as possible, and that's an important statement, provide clinically relevant challenges that mimic patient samples and have the effect of checking the entire examination process, including pre-examination procedures and post-examination procedures where possible. And they said that because giving a laboratory some white powder and say, pretend that this is a wound swab, well, white powder, wound swabs don't look like white powders. The only things that look like white powders are white powders, like cocaine. So there was a mandate for us to be creating samples that looked like typical samples. So with all that for CLIA and our provinces and ISO, there was a big light shone on proficiency testing programs to help laboratories get things right. So I show you this. This is what we provide in our program. When we send out a gram stain, as in here, it looks like a gram stain. And we send them a wound swab, it looks like a wound swab. And if we send them feces, a fecal culture, it looks like a fecal culture. It doesn't have feces in it, but it looks like it. And a urine sample looks like a urine sample. So we create these samples. They are all, we call them fresh. They are stable, stabilized. There's no white powder, there's no lyophilization. And the gram stains contain both host and microbial elements. So they are, in essence, a mini biopsy. We can do this sort of thing. Pathology laboratories can do this sort of thing. This is much harder for chemistry. It's very hard because chemistry samples tend to be much more unstable. And so they don't kind of go through this same sort of process as we do. But one of the things that we discovered and appreciate, and I hope you understand as well, is that proficiency testing programs have to have a quality mission. We are only as good as the quality demands that we put on ourselves. And so we have active internal and external oversight as a way of reducing error. And there are many problems that you may have with our samples, but in terms of going through a quality management system, there is nothing more rigorous than the programs that we do. When we make our samples, we have a national, in part international advisory panel that comes to Vancouver, and we spend 2 days thinking about what samples we are going to send over the next year. It's balanced regionally, so we have people from all provinces. It's balanced professionally, so we've got clinical microbiologists, medical microbiologists, PhD scientists, laboratory technologists, all working on this process. When we decide on a sample and we have isolates that we're going to send out, we send them out to multiple external reference laboratories to ensure that they are exactly what we think they are. We follow along a very intense quality control program while we're making the samples. And we go through two things which are required. One is homogeneity studies, and the other is stability studies. Homogeneity studies says that if we're going to make 100 samples all have to look the same. We can't have one laboratory getting something that looks like one thing and another laboratory looks like something else. They all have to look the same. And they all have to be stable. They have to be stable at least through to the end of transport, so that when the laboratory receives the sample, it is exactly the same as we sent it. And we have an active quality management system in which we do our own internal audits, our own external audits, our own opportunities for improvement. We go through the whole process. And we are externally accredited through the American Association of Laboratory Accreditation, using the document ISO IEC 17043, which is Conformity Assessment General Requirements for Proficiency Testing. And that document is currently under revision and will be available as a new document next year. And we also have our quality management system certified through ISO 9000, now 2015. When we started, it was 2007. And that is done through Standards Australia International, and it's done on a yearly basis. So we take our quality seriously so that people can know that they should take our samples seriously as well. So if the point of the exercise is not just to create a sample, but to assess it in a way that comes back with an understandable report, we had to create a scheme for creating that report. And we created what is known as the CMPT panel of grading, performance grading, CMPT performance grading. We created it. It's now used in multiple places across Europe. It's used in South America. And we work on a 4-point scale. 4 means that you did the sample right. Congratulations, well done. 3 is you didn't get it perfect, but it's good enough for rock and roll, and we will accept that as an acceptable answer. 1 is no, that's unacceptable. It was a problem. And 0 means if you did this with a real sample, you would have truly messed somebody up. So we have a scale that goes 4, 3, 1, and 0. And then to ensure total fairness, what we do is we put the samples through 2 external groups. One, which is a reference group. This is high quality. This is perhaps showing my own bias, but they're all high quality reference laboratories, many of them university based. And we put them through the total group. If we don't have 80% of the reference group getting the same answer as we expected, getting a 3 or a 4, or we don't get the total group at least 50% getting a 3 or 4, then we say there could have been something wrong with the sample. Maybe it was misinterpreted. So we take that out of the grading process. So we only grade those things that everybody can agree upon that was a good sample. And then what we do is we create the percent achievable score. And this is harder to talk about than to see, but what we do is we take, if we sent out 50 samples, we would take the 50 scores that they were given, and we'd sum those up and get a value. That was divided by the score as if they had received 4 for all their samples. And we call that the calculated achievable score.
C'est maintenant ta vidéo.
Hello?
C'est pas intéressant.
I'll keep going.
Yeah, go ahead, Mike. I just
I'll
muted
keep
it.
going. Sorry about that.
No, sorry about that.
Yeah, not a problem. So we have the total achievable score, or total score over the calculated achievable score, and we end up with something that looks like this. So this is the results from last year, and you can see that the vast majority of laboratories received got 100% on all their values, and that's what we'd like to see. There were a small group, about 10%, that got 90%, not 100%. But then you see there's a small number that got 80%, a small number got 70%. And while you can't see it, there's a small one there that got 50%. So what's an acceptable score? And the answer is, I don't know. I know what we score, and we created laboratory performance expectation. And that is that all laboratories, doesn't matter your size or your complexity, if you receive samples that were deemed as appropriate for you, you should be able to get a 90% achievable score all of the time. That these, what we call the left wing over here, these are laboratories that are not performing at a level that is of quality. And I would argue that if a laboratory is working at 70% correct, and you were one of the patients that got one of the 30% results, you might be annoyed that somebody allowed that to continue on. So we are comfortable with our 90% achievable standard. And there are other programs that are using that standard well as now. So this looks at results over the last near decade for CMPT, and you can see, and the results go back much further than that, but there were other laboratories involved, so I've only focused on 2014 to the future, to the present. And you can see, if you look at the left wing over here, there were a lot of laboratories that were not performing even close to what we would consider an acceptable level, 50%. You know, if you send out a result to that laboratory and you could get the same result faster by flipping a coin, one would argue that having the sample tested is a waste of time. And those kind of numbers kind of remained on until really about 2018. 2019, 2020, we're starting to get this pretty consistent 90% all of the time. So part of the reason that that's been happening is, in part, as you're probably aware, laboratories in smaller towns, places that have difficulty getting staff, many of those laboratories are being closed down, not only in British Columbia, but across Canada and across the world. So we're becoming this much more regionalized laboratory. And there's a lot of negatives to that. One of the positives is that you increase the likelihood of more accurate performance. I'm not sure that that's the only criterion to use. I would argue we'd be better off by training some of these laboratories and getting their skills up as opposed to getting rid of them. But I'm not the Minister of Health, and so I can give my opinion, but that's the decision that was made in this province. I think it's wrong. They think it's right. That's okay. So let me, let's see if I can do this again. Here we are. This is looking at specific results for which tests do people do well, laboratories do well with, and what do they do not so well with. Looking to identify microbes, we do pretty well. And it's been that way for a long period of time. And susceptibility testing, we do that pretty well as well. But in terms of reading gram stains, unfortunately, with some of the tests that are available and our less reliance on gram stains, the performance, the ability to read gram stains is falling off. I don't think that's good. I think that's bad. We've spent a lot of time working on this and have increased the number of gram stain challenges that we send out. Blood cultures, labs don't do very well with those. The samples are credible. They go through the full reference process, but there are laboratories that have a real problem, often with contamination of their samples. And there's another program which we have created, and I'm going to talk about it shortly, called the Paper and Video Challenges. And this is probably because it's new. And as we go along and laboratories get used to them, we will see this move closer and more to the right. So let's talk about laboratory performance in two specific areas. This is looking at the screening, molecular screening for MRSA, VRE, carbapenem-resistant enterobacter, and the looking at group B streptococci as a screening process. And this is the number of, this is what the sample was when we sent it out. You will see that in the vast majority of results, we get acceptable results. There are places, and here is one in particular, a VRE, where we sent out a VAN B. A substantial number did not very well with that. And correspondingly, we had VAN A that had some laboratories, not many, but some had problems with that as well. And so what that says is that if you are a laboratory, working in a laboratory that has doing a test called molecular screening, and you choose to use that as your definitive test for reporting, then you're to blame for these unacceptable results. This is a screening test and should not be used as anything other than a screening test. So,
Mike, just a quick question.
Sure.
How often do you encounter problems with sample stability and transporting the samples to labs, especially ones in more remote locations?
Almost never, because we spend so much time in getting our samples correctly stabilized. We have had some difficulties, not when the temperatures get low, but when we have heat waves in the Okanagan, we get temperatures over 40. That can create a bit of a problem. But within the range of minus 20, minus 30, up to 37, 38, we have no stability problems. Great,
thanks.
Okay. So what this says, once again, says, you know, we do fairly well with antimicrobial testing. If you, for the most part, does proficiency testing have a role to play in the battle against antimicrobial resistance? Well, it does if what it does is if what we end up doing is selecting out or pointing out the laboratories that are having problem doing susceptibility testing. And what we do is we inform people that their information should be looked at with some skepticism. Then that gives us a higher quality of information and antimicrobial resistance. This year, we got asked to get involved in proficiency testing for COVID-19. And we started off by doing it only for British Columbia, only for a small number of laboratories. That gradually increased to extend across the prairie provinces. And now we have laboratories as far as Halifax participating in our program. And we send out a sample which is made, which is provided through BC-CDC. It's a culture of a COVID, the original strain. It has been stabilized with beta-propiolactone, so it is non-infectious. We send it out in a number of concentrations, a high, strong positive, an intermediate positive, and a negative. And we can use the same samples both for PCR and LAMP testing, as well as for antigen testing. And it works, by and large, works well. And what we end up seeing we've now done a year and we have about 800 samples all together, and we're going to be continuing on next year. When there's molecular testing and we send out a positive sample, we get correct results 95% of the time. That falls within our criterion, that falls within the Canada Health criterion, so we would consider that good responses. And when we send out negative samples, we will get a small number of false positives associated with them. I think primarily from contamination of the samples in certain laboratories, but 90% of the negative samples come back with a 90% with a negative result, so that's okay. And when we send out negative antigen tests, we do very, very well. 97% of the laboratories correctly identify them as negative, but 3% report them as positive. But when we have a positive sample, in particular one that is not strong positive, labs do very poorly. And when you're at about a 75% performance and a 25% failure rate, that suggests there's a problem. And as we look at those results, we know that this is not a result of an inadequate kit. This is largely poorly trained people performing tests that they don't know or understand. Many of these are not laboratory personnel who are providing these tests. When they get retraining and they get their results markedly improve. So I think when we go through this.
Sorry, I think we've got a connection issue. Here we go, Mike.
But
sorry, Mike, you just cut out. Mike?
Yes?
Sorry, you just cut out about the last 10 seconds.
Okay, can you hear me now?
Yeah, you're good now.
Okay, thank you. So what it says is that what you knew intuitively is that the antigen tests, when you get those results, they are perhaps less trustworthy as opposed to molecular tests, either by LAMP or by PCR. Finally, let me go through this last part. There is a path of workflow which starts at pre-examination and works to post-examination, and it involves not only the things that happen in the laboratory, but also looking at collection and packaging and transport and what's happening at reception, report generation. All of these are critical things that need to be monitored along the way. In addition to that, there's some things that we call a para-examination. These are things that are not along that true workflow, but laboratory safety and laboratory competency and laboratory quality are all things that we need to know that laboratories are doing correctly because they all impact on their patients. This involves how do they handle spills? How do they handle fires? How do they handle injuries? How do they handle competency assessment? How do they handle training, internal audits? So we had to develop a technique, a method by which we could assess the competence of laboratories doing these things. They are not covered by the usual sample. So what we did is we created paper challenges, which is a question on a piece of paper, or we've done the same thing with video, and we don't have time to go through one of the videos, but they fundamentally work the same. Let me go through this one example. It says biological safety cabinets are recognized as important equipment in a microbiology laboratory because working within a cabinet can reduce the risk of spreading microbes from the sample to the workers or to the environment, as well as reducing the risk of accidentally contaminating samples. I think that's true, and I think you'd agree with that. Which of the following statements is or are true, consistent with the Canadian Biosafety Handbook, second edition, published in 2016 by the Canadian Public Health Agency? That is a standard that in this province, that's a book that is required to be present in all laboratories. And if a laboratory doesn't have it, first of all, they're breaking their accreditation. And second of all, if they have it, but they're never looking at it or never reading it, then that's like not having it at all. So it says, which of the following statements are true with respect to reducing the risk of contamination of the sample or worker operator while working in a biological safety cabinet? And we have 6 choices. One is that UV light is a powerful tool that is highly effective at reducing all microbial pathogens that are missed by routine decontamination procedures. The second one is products containing bleach must not be used in decontaminating a biological safety cabinet because it will cause irreparable harm. Waste materials must always be immediately removed from the interior of the biological safety cabinet while working because they represent a risk to both the specimens and to the operator. Never use ethanol in a biological safety cabinet because of its propensity to explode and flame. And all of those statements are correct, and none of those statements are correct. Well, if we were in a room, I would ask you and we'd get opinions. I can't do that this way. So I will tell you that the right answer is none of those are correct. Those are all wrong statements. And if you were to pick up the Biosafety Handbook, you would see that that's exactly the opinion of the Public Health Agency of Canada. That's the national expectation, and that's the provincial expectation in all provinces. So how did laboratories do? Well, most of them, we had 60 laboratories and 41 of them recognized that that was the right answer, that none of those were correct. Disturbingly, about 25% got it wrong. And really disturbingly, there were 6 laboratories that thought all those sentences, all those were right. Now, if you had, if you weren't sure and your laboratory has the Biological Safety Handbook, you pick up the book, you read the book tells you what it is, and you put in an answer. It says this is not a closed book process. This is answer the question properly. So this says that there are laboratories that are having problems. Now, we will probably do this again in a year, and we'll see how they do on this in a year from now. But I would say that this indicates a real problem in the para-examination area, laboratories not taking care of their biological safety cabinets properly, and that's a real problem. Okay, so if we get this system working, and I believe it is working, we can then say you've got a lot of check boxes that we can go through. We can in fact test not only along the path of workflow, but we can check the para-examination process as well. So using proficiency testing, we can be helping laboratories make sure that their information is correct, that they are not producing errors, and they are not putting their staff or their patients at harm. We then take that information and we publish it in our annual report. We publish it on YouTube. We publish it in critiques with every send out. We put it in the newsletter. And we also create a program for laboratory technologists that they can get their education credits with CSMLS through reading our program. So I think that this, I think we fulfill our mandate as a university-based program by providing a lot of education material. So EQA will work well, proficiency testing will work well, provided that the laboratories are as committed to quality as we are, that accreditation bodies are as committed to quality as we are. And I know that accreditation bodies are, and I understand there are some laboratories that may be less so, but the vast majority are committed to quality. So this system, according to CMPT, works well at least 90% of the time, and that's pretty darn good. So let me finish off by saying that proficiency testing is not kind of looking at some samples and that's the end of it. We cover the full spectrum of the laboratory cycle, and we are very proud of that. I want to thank Esther Kwok, who's our program coordinator. I want to thank Caleb Lee, who's our senior scientist, who is responsible for making most of those samples. I want to thank Veronica Rostelli, who's our scientist and editor, IT specialist, and is the person responsible for the COVID program. I want to thank Mafusa Sreya, who is a new technologist with us and still in training, but doing very good. And Shadi Alami, who is currently on maternity leave and will be coming back. Looking forward to that return. You can go to our website, https://cmpt.ca, and you can find a lot of information about what we do and the educational material that we provide. And finally, let me say that, and I'm really pleased that I've had this opportunity to participate in PALS. I've taken 3 or 4 shots at retirement. This time, I'm going to be leaving sometime this year. I think this time is going to take. Dr. Lucy Perrone will be coming here from University of Washington. She is a international expert on laboratory quality and leadership. She is funded through the professorship on laboratory quality. She's the first professor of laboratory quality funded in Canada through the Donald B. Ricks Family Foundation. And so with that, thank you very much for your attention. And if you have any questions, this would be a good time to ask.
Thanks, Mike. It's good to know there's a succession plan for your legacy.
Thank you. Yes.
I'll open it up to questions. Jen?
Yeah, I have a question for Mike. Mike, you were mentioning in one of your earlier slides that you were concerned about the decreasing trend in quality with the gram stain in some of our, I guess they're national laboratories. How big of a concern is that in Canada, considering that I guess most of us can afford the MALDI-TOF, at least in the major cities in Canada? Do you think it's still like quite a concern for us here?
Well, let me give you Mike Noble's opinion on this, okay? I think we've gone through this process many times in Canada and North America. We always get the new shiny bauble, and we get really enthused with it. And we think this is the most hot damn wonderful product that we can have. And a short time later, we say this is a piece of crap. And then we discard it, and next shiny bauble comes along. MALDI-TOF is a shiny bauble. And so, yes, it has some value. There are many places which it's at least as good as traditional chemical identification. There's some where it's terrible. And so relying on that as a step forward is not a step forward. What is a step forward is taking a sample and approaching it like a biopsy, which is what a gram stain is. You're looking at a sample that comes from a patient, and it contains human elements, it contains microbial elements. It gives you a notion of the type of inflammation that is there. Is a very high quality tool that laboratories use. And losing the skills at doing gram stains is pretending that that's okay. That's not okay. The reality is that 100 years from now, it may be slightly different, but there will still be a pair of eyes, a magnifying lens, and there will be a piece of tissue that's at the other end of it. And if you don't have that, then you've lost. And I think that multi-top is all very interesting, but I wouldn't invest all of my pennies in it.
Any other questions?
Well, I don't want to be a question hog, but I do have one more.
Yeah, go for it, Jen.
I just wondered what you thought about the level of quality of the testing, like for the COVID testing program in not only in the province, but in the nation. Do you think that we may be wasting our resources, or if you could give a percentage of how effective, or for example, a quality score for all the money we've been spending on COVID testing, what kind of a score do you think you might give it?
Well, let me offer a couple of thoughts. And first of all, let me say that what Mel Cratchit has done through BCCDC has been a yeoman's service. And I think that the BCCDC has served the province very well. But, and this is only my opinion, and he may be more than happy to tell me that I'm dead wrong. When you're working at 5 or 7 times your capacity, and you're having to bring in unskilled people and trying to train them up, the opportunity for error is huge. And so do I believe that all of their results are error-free? No. But it's probably it's well in the range. What we've seen is many people, and this is not to denigrate other professions, but we've seen people who are not laboratorians, who are not laborotechnologists, who are university students, scientists, some nurses, who have been tasked with doing a lot of this testing. And, if you don't know what a laboratory test is, and you've never done one before, then your chances of doing it wrong are high. And so we have a lot of those people in our system. And so am I surprised by the 25% error rate with the antigen testing? No, because many of those tests are being done by people who, one of the things that happens, and this is really being pejorative, and I apologize for it, but one of the steps along the way is you have to take a pipette and you have to put 5 drops into a little well. I would guess 20% of people can count to 5 and actually get 5 drops in the well. So the majority of people, they either don't read the instructions, or they do read the instructions that don't follow through with them, or they read the instructions, they don't understand them. And this is largely because this is not what they were trained to do, and they got recruited into this. And I think if that's the case, then is it a surprise when people have doubts about some of the testing? And the answer is, I think they're right to have some doubts on some of the testing.
Thanks, Mike. Well, I think we're at 1 o'clock, and I see Lucy's actually on the call here. So welcome, Lucy, and be good to engage with you in the future too. But thanks, Mike, for not just your time today, but just in general, all of the teaching you've given to all of us at UBC and BC as a whole. And I think that hopefully we'll still see you now and then. So I hope you don't completely disappear. And I'd be happy to engage with you if you want to be involved with PALS in the future.
Perfect. Thank you very much. I appreciate it.
Thanks, Mike, and thanks everyone for tuning in.
Thanks a lot.
Cheers.
Cheers.
Hi, Lucy.
I see.